After the two presentations.
Ah, okay.
Okay, thank you. Well, good morning, everybody. My name is Rosana. I'm from São Paulo, Brazil, and I would like to thank Dr. Emek for this invitation. And I will start to talk about how to deal with comorbidities, and then after me, Regis will continue this presentation. This is our disclosure. Well, comorbidity, as we know, is the presence of one or more additional diseases or disorders occurring concomitantly with a primary disorder or disease. Comorbidities may add layers of complexity, and therefore managing comorbidities is challenging, as one condition may contribute or be connected to another, and treatment may conflict. The objective of this presentation is to propose points to consider when dealing with comorbidities in patients with chronic spontaneous urticaria. First, we have to consider how to avoid or prevent the emergence of potential comorbidities. And second, how to manage patients with CSU and comorbidities associated. And third, how to assess the prognosis for these patients with CSU and comorbidities. In terms of prevention, it's worth remembering that CSU is a self-limited disorder with an average duration of 2 to 5 years, although 20% or more of these patients have a duration longer than 5 years, 10 years or more, or even more. Regardless the duration of the disease, the goal of treatment is to reduce disease severity and achieve complete control of the symptoms. Of course, early diagnosis of comorbidities will help following these patients, but we have to remember that we have to avoid triggers, for example, NSAIDs. And remember that mast cell has several receptors on its surface. This figure illustrates how mast cell could be activated by immunological and non-immunological triggers. You can see here lots of receptor beyond IgE receptor. Talking a little more about specific comorbidities, we know that CSU is associated in high frequency with psychiatric disorders. Relapse of symptoms several times a week or even daily have a profound impact on the quality of life and in psychological state of the patients. Stress is the major triggering and risk factor for these patients, and psychiatric disorder was observed in literature up to 30% of these patients. So screening for psychological health problems among CSU patients is a necessity, including multidisciplinary approach. And some chronic infectious diseases are too associated with chronic spontaneous urticaria. Regarding H. pylori infection, there are several controversial studies in the literature. H. pylori infection could affect a high percentage of patients with CSU, but the eradication of the bacterium does not appear to influence the skin condition nor its symptoms. Other studies. Eradication of H. pylori has a significant influence on CSU patients' recovery in parallel with the reduction of stomach inflammation features, and others reports of improvements in CSU up to 60% after H. pylori treatment were described in literature. Now Regis will continue.
So I'd like to thank you, the organizers. So we'll be continuing with these comorbidities, how to deal specific comorbidities. This is just a repeat from what was said before. So I'm not going to go through this very detailed, but basically when you have a patient who has CSU and parasitic infections, when you treat the patients, the frequency of the patients who have CSU who improve, it varies a lot. In the median is about 35%. But this is a new a way to pursue this problem, this comorbidity. It's a study from Israel that they show that CSU patients who travel to high-risk areas that were treated with antiemetic treatments, and they compared a control group, and they show that in these patients that travel to these high-risk areas that were treated, there was a reduction in the number of the improvement actually in the reduction of the symptoms and improvement of CSU symptoms, and the control group only 10% of the patients had improvement. So moving forward, I'm not going to talk much about this because it was said before, but basically when you deal with autoimmune disease, all the autoimmune disease that were mentioned before, we cannot have any studies that showed how to deal with them specifically in CSU patients. In other words, what happens if you treat the other autoimmune disease? Only in thyroid disease, you have that treatment with the patients who have dysfunction. You can have improvement very small, that difference between all the studies. You have improvement of the CSU symptoms when you treat this thyroid dysfunction. So with metabolic syndrome, so this is the same thing that was said before. Just want to point out that in this, there is a low grade of inflammation that has the same thing in CSU and all these comorbidities that are linked to metabolic syndrome, like the increased levels of IL-6, CRP, ESR, and also coagulation markers like the dimer, as was told before. And within the components of the comorbidities of the metabolic syndrome, the central obesity is likely the most important factor that may contribute to this inflammation. But although there are a lot of papers that show that there is a correlation between these two, CSU and the metabolic syndromes, as it was shown before, there is no papers that show that the treatment of all of this condition can somehow influence in CSU severity and the course, and this must be defined. So, when you talk about the management of these patients in general, it's very important first to identify the comorbidities in CSU patients. And also the treatment should be effective and aggressive and very early, and this might reduce the CSU disease burden. And this should be done with a multidisciplinary therapeutic approach. And also, it's likely that when you use the CRP as a biomarker, this might help in evaluating this treatment of comorbidities. And finally, when we talk about the prognosis of patients with CSU related to the presence of comorbidities, there is some papers that show that as the patient goes through the CSU, as long as it takes, for example, patients who have long history of CSU, the risk of autoimmune disease, inflammatory disease, and psychiatric disorders still increase. And it's very important also to point out that the new treatment that is available, the anti-IgE antibody, does not increase the presence of comorbidities. So, probably we would like to have this question to these experts. I think it's a very general question, that which CSU comorbidity, the ones that were shown, if we have any more ones that we want to talk about, is the most important, and how do you think, how you could deal with it? So I think this is an open question to the experts.
Okay, I think it's fair. Everybody of us says one word. I say stomach and esophagitis, GERD.
Yes?
Didn't you understand?
Yeah. Yes.
Oh, you didn't hear me?
Yes.
And how to deal with it. Look for Helicobacter, but treat the gastritis, esophagitis as well, because otherwise it won't work, as we published.
I can't do it in one word, and I think, I don't think we know what the most important comorbidity is as yet. We've heard about a whole lot of them, and some of these come from very small papers from certain parts of the world which may not be generalisable. So I think the severe asthma treatment trait model is a very good one for us to adopt in CSU. To talk about treatable traits, first of all you have to define them and then rank them in importance as to which ones are amenable to treatment and which ones determine response to the various treatments we have. And I think it is in the power of the registry that Carsten is leading that will ultimately give us the answer to this exact question.
I think that I cannot tell exactly which comorbidity is the most important. But however, if you think that chronic inducible urticaria is one of the comorbid, right now I think that this is the important one. But for other comorbidities, for example, infection, autoimmune disease should be considered because they are also comorbid. But previously, I have studied 450 patients with chronic urticaria, and there are many comorbidities or associated factors. Chronic inducible urticaria was detected in around 10%. However, there were many comorbidities. For example, infections such as dental caries, sinusitis, or even stool parasitic infestation, such as blastocystis hominis or Giardia lambdiasis. So I think it is not impossible that you will not treat. However, at that time, after infections were eliminated, not all patients, only some patients, their CU symptoms were relieved, partially relieved, but not completely controlled. Other comorbidities, common comorbidities were autoimmune comorbidities. For example, autoimmune thyroid disease, increased prevalence of thyroid antibodies in 16% and antimicrosomal antibodies in 12%. However, most of them were euthyroid. So sometimes I will not treat the patient with euthyroid with Eltroxin. Only some patients who have hypothyroid, and at that time, especially in recurrent case, I will try Eltroxin in combination with antihistamine. So that's very difficult to tell you. And positive ANA at low titer was found in 17%. However, only 1% was diagnosed as LE. So this is very difficult to tell which one is the most important one. That's my idea.
I'll just focus on one and say that I would like to focus on the anxiety and depression. And I would like to put one comment to what was said, because I really don't think that we should screen for it in a systematic way. But I do think that we should be very aware of this, and because we are that in all our patients. And you might wonder whether it's the fact that you have the CSU or the fact that you have a chronic disease that increases your risk of depression and anxiety. But in all of the patients that we see, and especially in the CSU patients, I think we should be aware of this condition and the increased risk of having one of these conditions. And when needed, we should know the instruments to screen for this. For example, the hospital anxiety and depression scale. I think that would be my point.
I'd like to agree with Connie and yourself, Christian. Most of our patients come in with psychiatric symptoms or depression, and it's a chicken and egg situation. You don't know whether the urticaria has caused the depression and anxiety. The patient will normally say that it's the other way around. They'll say, could it be I was stressed and then I developed urticaria? So that, I would say, is the commonest comorbidity I see. And I'm now participating at another trust in a psychodermatology clinic where we've grouped all our urticaria patients who have anxiety and psychiatric symptoms, and we're putting them on amitriptyline as well as their urticaria medication, and we're getting some very good results at the moment. The other comorbidities, I agree with Connie again, it depends where you live. Christian and I were discussing, we don't see Helicobacter pylori that much in the UK. I'm sure you'll agree with me as well. It's not a common comorbidity, but we do see thyroid disease, and often they already come in with thyroid disease, not having developed thyroid disease because we picked it up. The only other time we pick up comorbidities is in the UK. We do a lot of workup tests if they're going on cyclosporine or methotrexate, or they've already been on these drugs. So they will have had a hepatitis B, they would have had hep C, HIV, some of them will have had chest x-rays. And so we do come across patients where we haven't specifically asked for the tests for their urticaria, but by virtue of the drug they're going to have or have had, we might pick up comorbidities. So we don't always stick to the guidelines about which investigations to do or not to do, but I always do an ESR and CRP. Quite often I find my patients do have urticaria vasculitis. Either it's misdiagnosed as urticaria or it coexists. And that's a very important differential, not just with other types of urticaria as well. Thank you.
Well, I will comment on two aspects. The first one is the psychiatric comorbidity, and my question is always the same. I see a lot of patients that are distressed, they have depression and so on, but what comes first? So the question is it really a comorbidity, or is it a consequence of the fact that you have been having severe chronic urticaria for years maybe, and you are convinced you have a chronic disease, you will not heal? Because when you have an excellent response to omalizumab, you see the patients that are getting up immediately, and so the depression is disappearing, and also the stress is disappearing. They are happy, they enjoy their lives, and so I'm not that sure that the depression itself represents a risk factor for urticaria. This is probably a consequence, at least in my idea. The second topic that I'm interested in, of course, because I'm an allergologist, is the possibility that chronic urticaria is associated with a low prevalence of allergies. I don't think so. So I think that probably the two things come together with more or less the same prevalence as in the general population. But the presence of allergies, for instance, respiratory allergies or food allergies, represents a confounding factor when you look at total IgE as a prognostic factor for the response to omalizumab. So if you have, we published that recently, if you have allergy, you may have elevated IgE and don't respond to omalizumab, but this happens if you keep away the patients that are allergic, then you have the quite clear difference between the responders and the non-responders at the starting level of total IgE. That's it.
I'm Dr. Arnaud from Saudi Arabia, and it is our first time in the UK. So regarding, the issue of comorbidities, I think we don't want to mix apples and oranges. We need to know if is the presence of is a disease or autoimmunity, for example, a trigger or a comorbidity, because having a trigger like autoimmune disorders or autoinflammatory disorders is probably a trigger behind the manifestation of a chronic urticaria, versus having a comorbidity, for example, like having asthma at the same time, allergy, or having like an infestation with certain worms in certain parts of the world. And also coming with mixing, we don't want to mix it with the psychiatric disorder or psychological stress that the patient has, because this is like which comes first, the egg or the hen, it could be probably a complication. So complication versus underlying trigger versus an innocent bystander. So in order to overcome this confusion, probably we need to think of chronic spontaneous urticaria as a manifestation that we need to look for underlying cause for it. And then the best way to do it is to think, is it autoimmune? Is it auto-inflammatory, whether triggered by, infection or something else? Or is it a paraneoplastic? Or it's inducible urticaria that we, and then, or idiopathic, that means we cannot find the cause for. If we think about it probably this way, we can differentiate which is a complication and which is an underlying trigger versus which is an innocent bystander, like another allergic disorder that is there, like asthma, for example. So I think this is my opinion in the, in this comorbidity issue.
Well, thank you. We have very little time, Anna, and this is meant standardization and harmonization roundtable. Please give a short comment, because then I have to make a kind of voting.
I agree with you, Asra, that the atopic patients are a confusing factor when we assess biomarkers for chronic spontaneous urticarias, total IG. I absolutely agree, but you mentioned the metabolic syndrome many times. And such cofactors that are involved in the metabolic syndrome, in our population, 24% of the people started CSU after 65 years old. And they related with this type of comorbidities, not the younger. Then let's see. It's not like psoriasis. I don't think it will be like psoriasis. Maybe
Okay, I have to summarize now one thing. It is confusing. We have very different opinions. In the next guideline meeting, which is in December next year, we certainly have to give a little bit of more advice in the guideline how to go on with this whole discussion. And may I make a suggestion, because we say here, and the audience votes at the end of the session. We have a lot of different comorbidities. I would just like to ask you to raise your arms after naming one of them to see what you think is relevant. You heard long statements which were not exactly matching from the expert table. So if I ask you, who would say GI infection, Helicobacter gastritis should be looked at? Just raise your arms.
GI.
So that is something like, I would say, 12%. Whatever, I have to guess. Who says parasites should be looked at?
Certain parts of the world, yeah.
Regular, okay, 10%. Of course, knowing that in different populations it's relevant. Hepatitis, regular screening, 2%. Depression, 15%. 15.
50.
Yeah, but you can't count. Dude, I know him from guideline meetings. He always makes the sign at that, please, and everybody do the same, no? Okay, let's do 20%. Autoimmune thyroid disease. Okay, this is 50%. Neoplastic disorders. General screening. It's 4%. Allergic other diseases, comorbidities, rhinitis, asthma, atopic dermatitis. 20. Metabolic syndrome, 1%. Sorry. Okay. CIndU. Yeah, okay, well, I think that is not a comorbidity. It's in the guideline already. You should check for CIndU every patient. That's already clear. I think, who wants to check for CIndUs? If any hand stays down, I'm disappointed. Hey! Everybody has to check for CIndUs. You didn't understand the guideline. Okay. Anyway, you know we are going for lunch. And Amek, do you want to make a remark? It's at the restaurant.
Yes. Lunch will be served in the 6th floor.
Did everybody understand? Lunch will be served at the 6th floor, and those who don't find it really have a problem.
Yes, and we will have a photo together at the main hall here at 1:25. Come just 5 minutes before the session starts. Thank you.